You guys are amazing for hanging in here. I know it's a long day. I think it's great to see so many people who I saw last year. It's great to come back every year, and we were just commenting at our table how much we learn each year. It truly is an evolving landscape, and I know that's one of those phrases that feels like it's potentially overused, but things change so rapidly in this space, and it's part of the reason why I like prostate cancer. Really, you have to stay up on the data to keep our patients having the great outcomes that we need and they deserve. So I'm going to be talking about PARP inhibitors. We at Vanderbilt have an advanced prostate cancer clinic that is run by urologists, but we work very closely with medical oncologists. We do a lot of the oral agents, and when it comes to things like IV chemotherapy or lutetium, our medical oncologist colleagues will share in the care of the patients, but very much we rely on one another, and it is a very collegial and multidisciplinary care for our patients. These are my disclosures in the non-muscle invasive bladder cancer space. So we are going to talk about precision medicine and genetic mutations. We've heard a lot about that today, and I'm glad that there is so much repetition because it can be a lot of overwhelming information. Then we'll talk about the available approved PARP inhibitors, which also has changed quite a bit in recent years. We'll talk briefly about microsatellite instability before finishing up. So precision medicine, what does that mean? It means we are individualizing care for our patients, and part of what I love about prostate cancer is that it is very much a shared decision-making, whether we're considering patients with localized cancer or patients who have advanced disease. And we're taking into consideration a patient's comorbid status, prior surgical history, ECOG status, priorities in their care, support system, financial toxicity, all of this. But a big part of that now is genomic profiling of tumors. And we definitely have an advantage when we can incorporate that into our patient care for their decision-making. Genetic mutations, as we've heard quite a bit about, are relatively common in advanced prostate cancer. When there's genomic instability, that's when cancer develops. The DNA damage response pathway is one of the ways that we can help repair these damages and maintain stability. But when it's defective, that can play a really critical role in cancer development and cancer progression. We have heard a bunch about how homologous recombination repair gene-deficient prostate cancers make up a significant portion. In the screening arm, and in the screening for the PROfound trial, 30% of patients were found to have these homologous recombination repair gene defects. The range is somewhere from 20 to 30 in the available literature. Primarily, this is BRCA1 and 2, but there are certainly other important mutations that you've heard about, and that's why we have these expanded recommendations for genetic testing across the board in prostate cancer. This is also why we see this in the updated AUA Advanced Prostate Cancer Guidelines to identify these DNA repair deficiency, microsatellite instability, and tumor mutational burdens. Dr. Moses earlier had highlighted the Pritchard paper where in an unselected population of patients with metastatic prostate cancer, 12% of patients had identifiable mutations. It's certainly higher in the metastatic castration-resistant population of patients, and we know that these mutations portend a worse prognosis, so that's important for patient counseling, but also for treatment. Dr. Morgan's just showed you this, and I think at first glance it's overwhelming, But I also think that spending some time kind of digging into this helps us understand the current landscape. And while I wholeheartedly agree that what the lines are very blurred, what is first line, what is second line, I tend to think of this first box on the top left corner as kind of being first line. That said, when we get into some cases a little bit later, it can be confusing, and it is not well studied yet when patients have received novel hormonal therapy in the metastatic hormone-sensitive space, and then you're treating them in the castration space when they develop castration resistance. What does that mean in terms of these combination therapies with PARP inhibitors? If someone has received abiraterone or enzalutamide before, could you use that again in the first-line setting for these castration-resistant patients? So what is the mechanism of action of PARP inhibitors? We've learned a little bit about that already as well, but basically these are enzymes in our bodies that all of us have, multiple PARP enzymes, and their job is to identify when there's damage to DNA and then to recruit. So they identify and they recruit proteins that come and repair that damage. In cancer cells or BRCA mutated cells, other homologous recombination repair defects, you already have a damaged system. So then when you inhibit this PARP enzyme, that will lead to the accumulation of additional defects that result in cancer cell death. And so that is termed synthetic lethality. You're blocking the cell's one mechanism of repair with a PARP inhibitor, and that allows for cancers, or doesn't allow for cancer cells to repair themselves. Here is a list of some of the available trials. Like many agents that we see used in advanced prostate cancer, they're started in patients initially or studied initially in patients who have more advanced disease, and then they start working their way up to second line and then to first line therapy. So we'll go through some of these. In the single agent setting, we have two agents available, olaparib as well as rucaparib from the PROfound and Triton trials. And in our updated 2023 guidelines, we do see that these are recommended for patients who have homologous recombination repair gene mutated metastatic CRPC, in patients who have had prior novel hormonal therapy, although I don't know we can call it that anymore, enzalutamide or abiraterone, with or without prior taxane-based chemotherapy. So in the PROfound trial, this is a phase 3 randomized controlled trial for patients who had progressed on either prior abiraterone or enzalutamide. And all the patients who were enrolled here did have gene alterations. They already were mutated, and they had either BRCA, BR1 or 2, or ATM, which was one group, or 12 other gene alterations, not BRCA or ATM. And olaparib was compared to physician's choice, so either enzalutamide or abiraterone. And the primary outcome in a lot of these studies initially is imaging-based progression-free survival. And we see here this was favoring patients who had received olaparib over the abiraterone or enzalutamide. This was particularly true in the BRCA 1 or 2 cohort. Then rucaparib, this was initially granted expedited FDA approval in 2020 based on this phase 2 open label study that looked at patients, again, who had gene mutations, BRCA1, BRCA2, or another deficiency. And you can see the change in baseline, their objective response rate, either with imaging or with change in PSA from baseline. And so patients who were given the PARP inhibitor, rucaparib here, following failure of either novel hormonal therapy and docetaxel in this particular study did better in terms of their objective response rate. The final results from this Triton-2 study, the phase 2 study, showed that those who had the BRCA mutations had a better response, both in radiographic progression-free survival and in overall survival. Then in the phase 3 setting here, randomized control trial, we see rucaparib or physician's choice again. This did not require any prior docetaxel, so this was progression after novel hormonal therapy. And we see that the BRCA subgroup had the best response in terms of radiographic progression-free survival, but we do see some benefit in the intention to treat population as well. And so that's in the kind of second line setting. Patients have advanced or progressed through other therapy. But now we're seeing combination therapies being utilized, and this is more in the first line setting. So what is the rationale for combining therapies? Well, there's some synergism between these medications. It's thought that androgen receptor signaling regulates DNA repair. DNA repair has an effect on the androgen receptor, and so using the androgen receptor inhibitor can create this kind of BRCA-like or BRCA-ness state that makes patients more susceptible to PARP inhibitors in the setting of this combination, and there's discussion about might this be beneficial even in patients who don't have the homologous recombination repair gene defects? They're not approved in that state yet, but it is interesting to consider. So the trials that led to the approval, all in 2023, are listed here, and we'll go through them. There are other combinations being explored, and it is interesting, we saw in Dr. Barada's talk how they're moving earlier up in the treatment landscape now for metastatic hormone-sensitive prostate cancer. And actually, I just learned from Dr. Borjan that maybe in the biochemical recurrent space, PARP inhibitors are being investigated. So first, in the phase 2 setting, olaparib was combined with abiraterone in patients who had progressed with metastatic castration-resistant prostate cancer. And we can see here across the different populations that there is a benefit favoring olaparib with abiraterone in patients who have the BRCA2 mutations. That's that block B there on the right. But it was actually a benefit kind of regardless of the HRR status, which is interesting and kind of food for thought about that combination of therapies being synergistic. Then in the phase 3 study here, we can see that abiraterone plus olaparib leads to better radiographic progression-free survival across the different groups, whether it was central review or whether it was investigator review of the imaging. And then finally, in considering overall survival for these patients, because after we evaluate for radiographic progression-free survival and the data matures, we look to see what the overall survival advantage may be for these medications. We see a trend across the various subgroups for overall survival in each of the groups that received the combination, favoring the combination over abiraterone alone. But one important comment about this study was that there was no crossover allowed. So patients who had mutations in the control arm weren't able to receive olaparib, and so that may have impacted these results here. But nonetheless, the FDA approved this in May of 2023 for patients with BRCA-mutated CRPC. And this study was an all-comers study, so patients weren't pre-specified. Then talazoparib initially was evaluated as a monotherapy for patients who had progressed on prior therapy. And in this open label phase 2 trial, we see an objective response rate of about 30% for the combination here, and favoring BRCA2 mutations. In the phase 3 randomized TALAPRO-2, here we see, again, an advantage for all patients, better advantage for those who had mutations. And this trial separated the patients out after randomization into subgroups based on their status, their mutation status, as well as prior therapies that they had received, either docetaxel chemotherapy or abiraterone. And we see that the mutation status is important here in terms of response. And so that's a consistent theme across the board. And then finally, niraparib and abiraterone for patients in the setting of a mutation here. In this study, patients were pre-specified to have a mutation or not have a mutation, and those who had the mutation obviously did much better. Then we see the second interim analysis here. So not only the radiographic progression-free survival outcome was improved, but also secondary endpoints like time to cytotoxic chemotherapy or development of symptoms. So what are the adverse events associated with PARP inhibitors? It's important to consider that when we're looking at the initial studies that we talked about, Profound and Triton, those patients were really heavily pretreated, and so their symptom burden may have been more significant than those who are getting it earlier in the treatment course of advanced prostate cancer. But across the board, the adverse events tend to be similar, with anemia and even transfusion-dependent anemia being one of the most common side effects here. Patients then can have fatigue, GI symptoms, nausea, vomiting, anorexia, diarrhea. There can be thrombocytopenias and neutropenias, and less commonly, although certainly reported, venous thromboembolism. There can be problems, pulmonary issues, pneumonitis, and then theoretical complications related to myelodysplasias and leukemias. So what do we do in the setting of these adverse events? First of all, when they tend to occur, it tends to be early, so we see them 2 or 3 months after initiation of therapy. But if the drugs are working, then dose interruption versus dose reduction. Dr. Morgans was saying earlier, she tends to ramp up with these patients, but I think trying to limit the amount of drug that they're receiving to lessen the burden of symptoms rather than stopping it altogether can be preferred in some settings versus holding it all together and then kind of slowly reintroducing the PARP. So then microsatellite instability, we heard a little bit about this earlier. I just actually want to make one more comment too about the combination therapies. So in the studies where we're combining PARP inhibitors with the either abiraterone or enzalutamide, the side effects are as kind of expected with the combination. They're slightly increased, but not anything kind of different than we saw in the original trials for abiraterone and enzalutamide. But checking labs frequently and keeping tabs on these patients is really important. And so being in a clinic where you have the person power to regularly check in with these patients and make sure that there are no significant anemias or liver toxicities that need to be managed is important. Microsatellite instability, so another way that we can repair mutations is this mismatch repair system, post-replicative single-strand repair mechanism that is in place. When these mutations are seen and they're recognized and reversed, DNA-based pair mismatches. But when this system is broken, we have microsatellite instability, which can lead to chemotherapy resistance, but it can increase the susceptibility and sensitivity to immunotherapy. We heard previously that this is a small volume of patients with advanced prostate cancer. It's about 3% of this population. We have really limited evidence of the activity for patients with advanced prostate cancer, but this pembrolizumab was FDA approved in 2017 for patients with MSI high mutations who either have no alternatives to additional therapy or they've progressed on prior treatments. And this is commented on in the guidelines here for patients with mismatch repair deficient or microsatellite instability high, CRPC, we should offer pembrolizumab. So how did we get to this approval? Well, in 2017, there was a study that looked at these tumors across a host of different cancers, kind of agnostic to the site of origin for patients who had this mutation but had progressed following prior treatment and did not have alternatives. So this is really kind of an interesting idea and an important discovery that there's a shared tumor biology, again, kind of regardless of the site of origin. And the original paper on this looked at about 150 patients across 5 different studies. The majority of patients here had colorectal cancers, but about 60 or so of the patients had non-colorectal cancers, and including advanced prostate cancer. And we see a response that was durable in patients with these mutations. And so I feel that in practice more and more, we're identifying these and patients are doing well with pembrolizumab. So putting it all together, you have to consider the patient in front of you, their prior therapies, and their symptom burden before we're making decisions about what may be best for them. But PARP inhibitors really in the past several years have made their way into the world of prostate cancer. They have been around and used to treat other cancers for a bit longer, but it's exciting now that they are something that is oral and available, and really for patients who have the appropriate BRCA mutations and HRR mutations identified, can make a difference in their radiographic progression-free survival, overall survival, and we will see them earlier, as kind of pointed out before. So these are some of the ongoing investigations and trials in progress in the metastatic hormone-sensitive space, and I look forward to seeing that data come forth. So thank you very much.